Hello, good afternoon. This is Julieta Riveral Estrada. I am going to present peripheral intravenous catheter management. The goal for this lesson is to utilize current evidence-based guidelines for the management of patients with peripheral intravenous catheters. My target audience are nurses, patient care techs, radiology techs also, or any techs in the organization that would like to attend just for the knowledge. The context of this lesson is our organization is experiencing increasing rates of infection, especially IV lines and central lines. So our executive team had mandated for all RNs existing and newly hired from clinical orientation to take this class. So my instructional media is lecture, and I do a family feud game as an icebreaker to start with, and I give them handouts after the game. And after the game, I give them prizes and they love it. Okay, so my instructional media are PowerPoint, and I show them YouTube videos on several types of that's related to IV, like how to prime IV tubing, especially we have newly licensed nurses. That's why I have to cover this. How to prime IV tubing line, how to spike an IV bag for nursing, how to start IV intravenous insertion for nurses, and peripheral IV catheters removal. Okay, so when I start my class, I usually introduce myself. I say I'm Julieta Riveral Estrada, and excuse me, I'm one of the education coordinators in this organization, and I let the students introduce themselves, and I ask them, what unit do you work, and how long you've been with us, and what is your goal, why you're attending this class, even though if it's mandatory. And most will say, I wanna learn more how to start IVs, and some will say, I wanna be certified. And I will tell them that this is not a certification class, and this is just basically a familiarization class, and we practice on mannequins afterwards. Okay, so I'm gonna start my lecture. So procedure for placement. Trained personnel are responsible for placing or starting IVs, like your nurses. Patient care techs are also allowed to start IVs in certain parts of the hospital, but in the critical care areas, patient care techs are not allowed. And also you can refer them to, if the nurses cannot take or insert the IVs, you can call licensed independent practitioners, you can call medical residents, nurse practitioners, and or PAs. Okay, site, the IV site needs to be changed no later than or no greater than 4 days, that is 96 hours. If, for instance, the patient is a difficult stick, then that can stay more than 4 days, but you have to document the reason why it has to stay more than 4 days. When you convert the IV to saline lac, we also need an order. And we don't recommend putting IV or intravenous catheter lines in the extremities unless you're a trauma patient or you're a burn patient and you have no available veins in your arms and in the upper extremities. Catheter selection. For catheter gauge, size, and indications, we use 16 catheter gauge to 18 for surgery and or trauma patients. 20 gauge are basically for general patients with intermittent solutions. 422 gauge are used for children and the elderly, and 24 gauge for pediatric and neonatal patients. And in NICU, because I'm a NICU nurse, we basically use gauge 24. But I've heard that some med-surg units uses gauge 24 also. Peripheral catheter placement and dressing changes. Everybody knows that any procedure, we have to practice hand hygiene, okay, before insertion. Make sure that if you find or you witness someone not practicing hand hygiene, to make sure to stop them and remind them that it's very important. So the first thing you have to do, you have to check the orders, gather your supplies and equipment, and go to your patient. And talk after hand hygiene, you have to talk to the patient the reason why you have to start an IV. Okay, so we make sure we put it on the non-dominant upper extremity arm, so it will not be bothered or it will stay longer. Okay, the vein size and catheter gauge has to match. If I am an elderly patient and I have pliable or very not so good vein looking, you have to put like gauge 22, not gauge number 16 on a tiny vein. Okay, so if a patient is a difficult stick, you can use a vein locator, which is available in our units. And sites to avoid, you avoid those. If you're an adult, of course you avoid the sides here, okay, and lower extremities. And if a woman has a right-sided mastectomy, you don't put the IV here, especially if the nodes were taken out, because it can cause edema. All right. You prepare the skin for IV insertion and make sure you remove the tourniquet after insertion. Then stabilize it with a securement device. Okay, so if the patient is a difficult stick, we only are allowed to stick the patient twice. And you can refer to another nurse in your unit, or some techs. Some patient care techs are better than some of our nurses because they've been there a while. So that second person is also limited to 2 sticks. If it will be unsuccessful, you need to refer them to the licensed independent practitioner, which are your medical residents, PAs, or nurse practitioners. And we need to document unsuccessful attempts in the power chart. All right, catheter patency, flushing, and locking. We use catheter access needleless system only. That's what we have to prevent infection. And for disinfection, we use chlorhexidine gluconate or 70% alcohol. We also have these Curos cups to use for passive disinfection process. If your IV has 3 prongs, what's that, 3 openings or prongs? Not openings, 3 ways like that. So one is used, then the second and the third, for instance, is not being used. You can wipe that with alcohol and put the Curos cups. That's what we use for passive disinfection process. Okay, if somehow there is a resistance that you met before, like when you're flushing your IV, do not force it. You have to remove that and restart it. Okay, we use normal saline for flushing, and in that site, in that IV site, we don't allow or we don't recommend to draw blood from the IV site. Some nurses told me it's okay to do that during insertion. You can do that. if it's easier, and if you think that the patient has good IVs, I mean good vein, you can do that initially, but not on an everyday basis, because you're technically taking it off and introducing infection. So that's not a good idea. So catheter device locked is used after medication. That's the Curious cups, and we need to monitor the site every 8 hours. Okay. So in the NICU, our IV pumps are defaulted to beep every hour. So you basically go there, reset your pump, and look at the site. So I've heard that mid-surge areas, you don't really check your IV site every hour. So it will be a good idea to, like, when you go there, you're doing something for the patient, like you're giving them ice, or they need something, they need you for something, or you're giving medication, kindly check the IV, so to make sure that it's patent and it's not infiltrated. When you're flushing the site and the patient feels pain, stop infusion right away and restart it. Okay. So, and also remove the IV catheter for complications, and for severe infiltrations, make sure you refer them to the one consult, or you do a one consult in the one department. All right, catheter, tubing, and fluid changes. Peripheral catheters are good for 96 hours. That's the max, unless if there is a reason that it needs to stay. For IV tubing, Curious cups are being used. Primary, secondary tubing is also good for 96 hours. Your primary tubing needs to be changed daily, of course, especially if you're putting TPNs in intralipids. You need to change that. Or if disconnected from the IV port. If you have to disconnect the primary tubing from the IV port, then you have to change that daily also. What about the secondary tubing? That needs to be changed daily if disconnected from the primary tubing. And mostly if you do change TPN lines, the TPNs or lipids every day, like after, we usually change it, at 2 p.m. in our organization, then you must change the whole thing, okay? Change flush lines also every 24 hours, and IV fluids change 24 hours also. Dressing changes. During new insertion, we use the dressing that is transparent in there, okay? And then you can change it also when it's soiled, when it's leaking, and there is serosanguinous drainage in there. For non-transparent dressing, change every 48 hours, or PRN. Again, use your critical judgment. When you see that there is some serosanguinous or bloody drainage there, you go ahead and change it. Documentation. After you start the IV, you document the insertion date, initials of procedurist, on the catheter dressing. So when you put the dressing on, you have to date it, initial who did it, and who did it. Like today is 9:30. My initial, and on the catheter dressing, and also documentation. Date, put the date, time, the IV fluids hung, and label the tubing for the date that needs, or the change date, like when would it need to be changed, sorry. Medical record documentation are the following: insertion of catheter, date and time, insertion site, left arm, type, and catheter gauge, number of attempts, 1 stick, hopefully, and what is the condition of the site, if there's no drainage or anything, and if there is an infiltrate or phlebitis problems in the patient's IV site. Okay. Also, dressing, patency, and equipment use, and of course, when you discontinue an IV, you have to document what time and describe the site if it's all right. There's no signs of phlebitis, there's no signs of anything. And in the process, even before starting an IV, during checking and all that, we have to educate the patient and or the representative and make sure that they know what is the importance of this IV and what to look for and what to watch out, especially if the patient has a watcher or a relative that stays all the time. You can ask them to, be on the lookout. Okay? All right. So here's my references: Centers for Disease Control and Prevention, and Infusion Nurses Society, and Lippincott. And I'm gonna give this PowerPoint lecture to the nurses in my handouts, and also midway I show them the YouTube videos on those things that I mentioned earlier. And what else? And I normally ask them for feedback right there and then what they learn best, or that's what I do. I ask their feedback and then I modify my lectures for the next classes, because I teach this class once a month or twice a month. Thank you very much, and hopefully this is all right, because it's hard if you don't have students. I don't normally sit down. I like getting up and getting involved with my students. I'm talkative, I'm an extrovert, and that's why they like me. All right, thank you, bye.